ASICON team and Dr. Shinde and team for making me a opening batsman. Today, in next 8 minutes, 8 slides, I am going to just give you an eye-body view of concept of abdominal wall reconstruction and the best plane for the mesh. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. Now, all of us have been practicing hernia surgery for, I would say, 4 decades. We started with Bassini, Scholdi's, Lichtenstein, ventral hernias, anatomical repairs, and so on and so forth. And I would say that all of us have made so many mistakes and so many lessons we have learned. For example, if these kind of hernias present to a novice young surgeon, I would say that please withdraw yourself. That is the biggest lesson one can ever learn. That if you withdraw yourself and send these kind of hernias to your enemy, that will be the best thing you can ever do. So choose the approach well. And again, I want to reinforce in the mind of my younger surgeons is that hernia science is not a manual laborer science. It is a cerebral science. So one has to carry on thinking before, at the time, and post-operatively. So, and one should always think that one trouser does not fit all. When we start doing the abdominal wall reconstruction, all of us have been doing the laparoscopic repair, TEP, ETAP, TAPP, and so on and so forth for ventral hernias, also then ETAP RS. Then we realized that ultimately there is a subset of patients who require especially the abdominal wall reconstruction, and reconstruction would mean that it is a tension-free approximation of well-vascularized tissues, reconstruction of the linear elbow. What I mean to say that most of the times, most of us were never thinking about the functional restoring. We were thinking that we are doing anatomical repair and that's it. But now the concept of abdominal wall reconstruction includes that one has to make sure that the reconstruction is there, reinforcement is there, but the functional anatomy has to be restored. And it can be, there will be many situations in which one is not able to do the reconstruction without separation of the components. So we have to know the anterior component separation, posterior component separation, and then one has to make sure that the reinforcement has to be done with a mesh which is of the size of maybe 30 by 30 or even more. And then one should again and again make sure when we are doing the abdominal wall reconstruction that the surgical site infection is to the minimum. And there will be n number of indications, but most important abdominal wall reconstruction indications would mean that we are dealing with recurrent hernias. So if there are recurrent hernias, then only we will be able to offer the best to these kind of patients. And there are n number of options. There are n number of belling a cat. So one should know that if, for example, one has to place in a mesh with only repair, if some surgeon out of this faculty also says that no, IPOM is dead, I would not believe it. If some senior surgeon says that IPOM or the only mesh has lot of complications in the form of sinus formation and so on and so forth, I still don't believe him. What I mean to say that there are specific situations for which the IPOM is the gold standard. And it has been the gold standard for so many years. IPOM Plus has been the gold standard for so many years. And it has tested, it has been seen that there are defects of the size of 3 centimeter, 5 centimeters, 6 centimeters that one can do with IPOM. But if the defect size is larger than 8 centimeter, you have seen the CT scan also, then start planning in your mind where is the best mesh placement has to be done. So whether now one can see that onlay mesh is there, or inlay is there, or sublay is there, or IPOM is there, but again and again, you can see the recurrence rates also. Retromuscular repair has a recurrence rate of the order of 5.8%, and pre-peritoneal has the recurrence rate of 12%, and intraperitoneal 10.9%. So what I mean to say that the quantum of surgeries which are being done and the percentage you can see, so lot of recurrences are still occurring, even if all of us are trying our best to give a duck recurrence, but we have not been able to do it. So again, our thinking is, even if you were or we were doing the TAPP, TEP, ETAP or open anatomical repairs for ventral hernias and whatnot, but again, this anatomy is absolutely different, and God lies in details, devil also lies in details. So we have to immerse ourselves in this field of abdominal wall reconstruction, and then only we'll be able to offer the best to the patient. And to my mind, retromuscular mesh placement has the least recurrences and complications. I am not going to bore you with this busy slide, but definitely one should know, and there are a lot of literature is available which tells us about the mesh and the plane selection, and one has to make sure that whether we are doing by open method or by laparoscopic method, what if there is a chance of seroma or hematoma in different techniques, onlay, inlay, sublay, or and mesh explantation, mesh recurrence, mortality, and overall complications. So our thinking is loud and clear that we should immerse ourselves so much into the detail and then only offer the whatsoever the latest techniques are there. Yes, all of us know that seroma is there, but I would never ever say that right from word go, that if the seroma is there, aspirate and then send the patient back. No, one has to carry on waiting for some time, 3 weeks. Another 3 weeks, and usually the seroma 90% will resolve themselves. But if they are not resolving, then there are situations that one has to excise them also. Excise the sac, take out the seroma, and then offer the best. So our thinking is, please do not go and start the abdominal wall reconstruction today, because you have heard a lecture of Dr. Shinde or Dr. Sarfraz or anyone, but go and attend their operation theaters, see for yourself that what kind of thinking has been there pre-operatively, per-operatively. CT scan has to be seen by the younger surgeons in the CT room itself. One should go and discuss with the radiologist, try to learn pre-operatively, per-operatively, where exactly was the hernia, how much withdrawal of the muscles was there, and then only offer the best to the patient. And I would reiterate by giving a statement of Restopa, for ethical, professional, and economic reasons, these are the days of hernia surgery without recurrences. And again, our message is loud and clear. Please stay updated, and the latest techniques and guidelines should be seen. Perform through pre-operative excellent planning, maintain meticulous intraoperative technique, ensure an adequate experience, and then monitor the patient in the post-op period also, and try to learn from your own mistakes rather than mistakes of others. Thank you very much for your kind attention. Thank you.